The next talk is going to be developing an algorithm for treating cervical deformity, and our current CSRS Vice President, Chris Shaffrey from Duke University, is going to give that talk.
Well, great. Thank you, everyone. And I'm going to build a little bit with the great talk that Adam just gave. These are my disclosures. So one of the things I think that as we have some of the younger people in the audience, and when you're looking about cervical deformity, there's some people that have a little bit of loss of cervical lordosis and say, I'm going to operate on this person because they've got that bit of kyphosis. But when you're talking about real deformity, it's something that you may want to walk into with a little bit of trepidation. This is a recent paper from Justin Smith and others that looked at cervical deformity and compared it to thoracolumbar deformity. And basically, by looking at all aspects of frailty, disability, other comorbidities, this is a substantially worse problem. And this substantially worse problem results that this is a patient population fraught with horrific outcomes, multiple comorbidities, multiple complications. You want to go in this with your eyes open. So when you're looking to deal with something like that, you just want to make sure that you're not biting off more than you can chew as you head into that. Now, when we're developing an algorithm, we need to have a starting point. And I think Adam gave you all these points, and Chris Ames just did a phenomenal job sort of putting them down as a deformity classification that looked at the C2, C7 SVA, looked at the chin brow, looked at cervical lordosis, looked at a myelopathy, but also realized that many of the patients who have a supposed cervical deformity also have deformity elsewhere, and put in the SRS Schwab classification. And you've seen these things that were just nicely outlined by Adam. And and again, some of the things are really important. For example, that T1 slope is kind of the base of the cervical spine. And how the cervical spine compensates for that really impacts how much deformity is present. Now, Adam went and talked a second ago about kind of the C2 slope, the holy grail. And why this is a holy grail is by knowing what the C2 slope is and knowing what the T1 slope is, you know where your deformity exists. So if you have a high C2 slope but a normal T1 slope, your deformity exists completely within the cervical spine. On the other hand, if you have a high C2 slope and a high T1 slope, then you have both a cervical deformity and a thoracic deformity, and frequently you have to correct both of those to be able to adequately correct. So by knowing C2, knowing T1 slope, it really helps you focus in on doing that. So one of the important things is knowing where the location of the deformity is. And I'm using this as a case example. This was a 46-year-old who was sent to me after 3 surgeries for thoracic kyphosis, and she came in with horrific, unremitting neck pain. And they sent her for me for a cervical deformity operation. Well, we look at all these different measurements and we look things, and guess what? Her C2 slope is normal. Her T1 slope, however, is really, really abnormal. And if you see the McGregor's line to C2 angle, it's extraordinarily high. And what she's doing is impinging upon her greater occipital nerves because she's having to hyperextend at the craniocervical junction. So when she came in, she said, "What are you going to do to my neck?" And I said, "Oh, I'm not doing anything to your neck. I'm doing the rest of your spine." And this is what I did to the rest of her spine. And 2 years later, she's working as an accountant. Her NDI is 10. And you can see all of those values return to normal. So knowing where you're looking becomes critically important. So this algorithm requires 36-inch films or EOS imaging for your planning, knowing where exactly the different abnormalities are coming. In certain cases, again, particularly for someone with a fused spine like ankylosing spondylitis, sometimes it may be from several areas, and you may make a decision to correct a deformity at the area where there's the least surgical risk. For example, doing a lumbar pedicle subtraction osteotomy in someone with ankylosing spondylitis despite them having some cervical thoracic kyphosis. So basically, this cervical lordosis T1 modifier goes and shows the ability of the cervical spine in part to compensate. And again, the SRS modifiers. So next thing we want to look at developing an algorithm is the magnitude of deformity. And so what's happening is when you see somebody who's like this, and like this, and like this, you've got to go and then, sort of go and unpack this and decide what you're going to do and how much you're going to do. And so I did this operation, and you can see the patient's chin's no longer on their chest. And I said, okay, now I'm going to do your L4 pedicle subtraction osteotomy. And she said, oh, hold on now. I'm pretty happy the way I am right now. And I think we'll put that pedicle subtraction osteotomy into the future. You want to understand the flexibility. Again, here's another rigid deformity, mostly at the cervicothoracic junction that's there. And because of this, I did an upper thoracic 3-column osteotomy to correct the deformity. Here's another person which I thought there was a fixed deformity, but with a little bit of traction. Again, this is a stiff spine, not fused. I was able to do a much smaller operation in the grand scheme of things to be able to get the degree of correction and get good overall alignment. Here's a circumferentially fused spine, and again, you can see here that going and exposing the vertebral arteries, going and doing an aggressive circumferential osteotomy and a realignment done. And then finally, we want to know whether there's neurological compression. Here's someone with severe compression at the upper thoracic area, which factored in my decision to do a 3-column osteotomy, do a vertebral column resection to take care of that ventral compression on the spinal cord. Then finally, we want to know how big of a surgery do we want to do. And so again, you can see that big deformity requires big surgeries with this. So one of the things we have to understand is as we do bigger and bigger surgeries, the risks, the complications, the recovery all increase. This is a really nice study put together by Peter Passius looking at the invasiveness index, okay? And what we have to decide sometimes, is it worth doing it? And as this invasiveness index increases, the risk of us having a horrific complication, and some of these complications, we're at like a 300% complication rate to do it. So finally, this is the take-home slide. This is actually a paper by the Jefferson group, and this goes through the different specifics that are going to be available. But basically, if it's flexible, you can go in from the front or the back. If it's fixed, you're going to need to do a 3-column osteotomy or a circumferential fusion, and it goes through all the different specifics as far as the different treatments are concerned. So if you look at it, and again, it gives the reference from Neurosurgery Focus, but you can see whether it's stiff, it's flexible or not. The only other thing which is not included in here is I am someone where it is stiff, but not completely fused. I'm somebody that will put people in cervical traction for a few days beforehand to try to go and spare them a 3-column osteotomy if I'm able to do so. So the fact is that this is a complicated topic. There's a lot of different factors that are part of the decision-making with it. And I think that, again, you want to go into this with a little bit of forethought for some of the most difficult, and certainly you want to go and run that by some of the experienced members of the CSRS if you're going to go and try to bite this off to make sure that your thinking is appropriate. So basically, these are the high points. The individual approach is used to maximize neural decompression, achieve sagittal and coronal alignment, long-term stability, but these are substantial operations. Thank you.
I have one for Hanjo. So I enjoyed your talk and the selection of UIV, LIV, and the classification system. One of the deformity types that doesn't fit so nicely into that classification is a dropped head, because it can look rigid in a flex-X unless you put the patient supine. So technically it's like a cervical thoracic junctional deformity, but if it's truly supple and flexible, do you have to go pretty low in that case, or can you stop up at like T2 or something like that?
I mean, I think if you have somebody with a dropped head, I'm guessing like the T1 slope's pretty high, their C27 is really elevated, and their cervical lordosis is probably like half of their T1 slope. Is that the patient?
Well, it would be someone who's sagittal backward in their thoracolumbar spine with a low T1 slope. And then the dropped head
very
brings
high
their
pelvic
neck
tilt.
down. So C2 is really high, like those examples that Chris was showing with high C2 slope,
Yeah.
low T1 slope.
Yeah, I mean, I think, you know, if, in that case, I would probably call it a type 3, and I would go long, you know, like C2 to like past the cervical thoracic apex, and past the thoracic apex down to like T10 or T9, depending on what the radiographs look like.
Yeah.
Yeah,
It's
I'll
always
just
tough to-
add, you know, wherever you go, wherever you pick is going to be wrong. So what's happening is I usually go down to T4 because that's the origin of the semispinalis cervicus, which has most of the cervical extension moment. So I go across that entire area. But what's going to happen is that, you know, those patients, I warn them, there's probably a 50% risk over time that they're going to develop DJK because they've got a underlying muscular problem. And I've sent off muscle biopsies and everything else, and sometimes stuff comes back and sometimes it doesn't. But then you go down, you know, to me, then I go down, the next stop is usually either, you know, the thoracolumbar junction. You know, some people say you take it to the first couple lordotic segments, and then they seem to pitch forward. So I tell a lot of people that I'm doing a drop head case on, this may be one of 3 or 4 or 5 operations that eventually results in you being fused to the pelvis. So, I mean, I have 2 or 3 or 4 of those patients that are fused from C2 to the pelvis because I've slowly marched them down the spine. So I don't have, we've tried rehab, we've tried, you know, all sorts of different things to do it, but I think it's a fundamental neuromuscular problem, and I think that unfortunately you're at risk of end up doing very, very large cases.
I mean, I think the answer was contained a bit in your question for me, is that they had the ability to retrovert, so their lower compensation was actually intact. And one of the things I think we're guilty of, just like we were in Parkinson's disease, is we lump all neuromuscular dysfunction together. And really, my belief is we have to do a much more specific, patient-specific assessment of the exact nature of their extensor muscle dysfunction or their neuromuscular control to try to figure out our termination level. In a sarcopenic patient, age through senescence leads to sarcopenia. I agree with Chris. We've actually been taking those patients down to the pelvis at the index operation when they have a cervical thoracic deformity and they're sarcopenic. But I think it's more complex than just saying, oh, they have a dropped head from a neuromuscular deformity, they need to have this LIV.